Feel free to ask any question at any time during the webinar, but please use the Q&A button on your screen, not the chat. Lisa and Michelle will address as many questions as possible at the end, but please use the Q&A button. That way we can see them all in one spot and they won't get lost in any chat. So please use the Q&A button for your questions. And again, we'd love to know what topics are on your mind, what you'd like to see in the future, what you'd like to see on a webinar. So please put those ideas in the chat if you have them. Your ideas for future topics in the chat, questions in the Q&A. All right. I'll introduce your speakers real quick here before we start with our agenda. So Lisa Selman-Holman is the Vice President of Clinical Services for McBee. She has more than 35 years of experience in home health and hospice, specializing in regulatory compliance, both as an RN and a home care attorney. And Michelle Horner is a clinical consulting manager for McBee. Michelle has over 30 years of experience in healthcare with an extensive background in critical care, home care, and hospice. She specializes in quality, clinical, and regulatory consulting and education. All right, without further ado, I'll pass it to Lisa to get us started.
Okay, our agenda today is to understand the SFV basics, so that's symptom follow-up visit, and that's to gain an understanding of what the requirements are within the HOPE assessment to support compliance and quality, and how that will impact your hospice staff. So these SFVs, I'm sure you're doing something that will be a symptom follow-up visit, but it's not the official symptom follow-up visit required by HOPE. So learn how those will affect daily operations so you can craft a survival plan for navigating this transition. Now, I want to repeat what Ken has answered to Crystal. Today's content is generally on the guidance itself. It is not directed to just NetSmart users at all. So we're talking about how this will impact the whole industry. So CMS will likely release clarifications on aspects of HOPE between now and October 1st. We don't know when that will happen. We have received an email from CMS that said that they realize there are errors in the HOPE assessment. I mean, not the HOPE assessment, but the HOPE manual. So the HOPE manual is supposed to be final, but there's a lot of errors. So they will likely release clarifications. They said they would, but we don't know when that will happen or what they will look like exactly. But it's important to stay informed. So this is a HOPE resource page. And so link to this and visit it often, okay, so that you can see that when those things are updated. And we will continue preparing for October 1 based on the official published guidance related to topics like the symptom follow-up visit and the hospice update visits, the HUVs. So let's get our acronym straight. So HOPE is standing for Hospice Outcomes and Patient Evaluations. Then we have the HUV, which is a HOPE update visit, SFV, which is the symptom follow-up visit. We have IKEYS and KEYS. Now, the QIES in that stands for Quality Improvement and Evaluation System. What you have been submitting your HIS to is called the KEYS. You will submit the hospice Outcomes and Patient Evaluation Assessment, the HOPE, to IKEY. So that's a newer system and it's internet-based. The HCI is the Hospice Care Index. HVLDL is hospice visits in the last days of life. And then CAPS, we have CAPS for all the providers, but we're really talking about the CAPS for hospice here. And so that's a consumer assessment of healthcare providers and systems, better known as patient satisfaction, rather than saying all those words are just CAPS. So we will start using the HOPE tool on October 1st, 2025. That is the effective date. And the primary objectives of HOPE are to provide quality data for HQRP. So that's the Hospice Quality Reporting Program through standardized data collection, support survey and certification processes, as well as inform future payment and quality improvement refinements. So CMS has been talking about a new payment system for hospice for a very long time, years and years, and perhaps they're finally putting something into place. We know that they will take money away if you don't submit your HOPE. So it is sort of a payment issue, but it's not really a payment change at this point. The data is collected at baseline, along with status changes and outcomes at other time points, will contribute to the updates to the hospice plan of care and support providers' quality improvement efforts. So these quality measures based on the HOPE items are described in the HQRP Quality Measures User Manual. And I believe that's still in the draft form, isn't it, Michelle?
It is. The draft is out, and we're not sure when that final version is coming.
We have asked, and they have not answered. So beginning October 1st, 2025, HOPE data will replace the HIS data for timely submission as a factor in determining hospice's compliance, and all data collected at the HOPE time points, and there are 2 extra time points there, must be submitted and accepted on time. So again, I'm going to say the submission to CMS will be done via IKEY, so it's a different process than what you've been used to. But we have a compliance threshold, and we've had living with this compliance threshold for several years now. But remember, the compliance threshold is 90%. And so 90% is still the compliance threshold for HOPE, as it was with HIS. And so if you're not compliant, you're looking at a 4% reduction in payment. Now, after October 1st, hospices will only use HOPE for the collection of this data. The HIS will no longer be accepted for new patients. For existing patients admitted prior to October 1st, using the HIS data set, the only time point required is a HOPE discharge after October 1st. So in other words, if they're admitted in September and you do an admission in HIS and they expire in October, you're going to do a HOPE discharge. So who does this apply to? Which patients do we have to complete a HOPE on? Really everyone. So it applies to all patient admissions to Medicare certified hospice program, regardless of the payer source. So whether it's Medicare, Medicaid, or private payer, many of you have lots of Medicaid patients, HOPE will be required on those as well. Regardless of the patient age, so whether they're pediatric or they're 104, it doesn't matter, you're going to complete a HOPE on them. Where the patient receives hospice services, and we've received several questions about that. Well, what about, inpatient? Well, yes, you still have to do a HOPE for those inpatient patients. So hospice services, whether they're in private home or nursing home, assisted living, or a hospice inpatient facility, you still have to do the HOPE at the appropriate time points. And it doesn't matter length of stay either. Now, again, those patients that were admitted prior to October 1st will only need a discharge in HOPE. So whatever the circumstances of discharge are, they'll need a hope discharge. You're not required to do those hope update visits for those patients that were admitted prior to October 1st. The three criteria needed to require a hope assessment, essentially, they have to be admitted. So there has to be a signed election statement or other agreement for care if it's not a Medicare patient. So we know we have an election statement for Medicare patients, and we have some other form for patients who are not Medicare. So regardless, they've signed an election statement or whatever the other one is called, depending on the payer. The patient did not expire prior to that effective date, and then the hospice made a visit in the setting where the hospice services are to be initiated. So those three, if all of those are true, then you must complete a hope. If any of those criteria are false, then hope is not required. So here's a couple of examples. The patient signed an election statement Sunday, effective date Monday. The nurse went to the patient's house Monday afternoon, and the patient had actually expired prior to arrival. So in this case, the hope is not required because the patient expired prior to. So even though the patient already signed the election statement and survived to date of election, the patient expired before the visit could be made in the setting where services were to be provided. So that's why it's red. Blue, this is one of those things that, hey, this is what Medicare says. Consent signed on the admission date. The patient expired during the admission visit. Medicare says the hope is required. So the hospice should complete both the admission and the discharge record with any hope data collected during that assessment visit. And of course, the hope update visit would not be expected.
I think that one's an interesting example that you're doing the admission, but you have to have that ending time point. So even though they expired while you were there, you're not just doing the admission. You're not doing the admission. You've got to do the admission, but you also have to do a discharge.
Mm-hmm. So we want to make sure that everybody's on the same baseline here. So we have a lot of information on the time point and the time frame prior to getting into that SFV. But the hope admission is collected as part of the comprehensive assessment at admission. And you have 5 days to finish it. No later than 5 days after the effective date of hospice election. I should say 6 because we have the hospice election date in 5 days. But you have 5 days to finish that admission. And it's even kind of a little loose as far as completion because Medicare is giving you a guideline to say it needs to be completed no later than 5 days after the effective date of hospice collection. Then you have 2 hope update visits, HUV1 and HUV2. And these have to be an in-person visit to inform updates to the plan of care. So HUV1 is required between days 6 and 15 of the hospice stay, not in the first 5 days. And then HUV2, again, in-person visit to inform updates to the plan of care, is required on or between days 16 and 30 after the hospice election. And then we have the hope discharge. Why that patient's discharge doesn't matter, but data is collected at discharge for any reason listed in A2115. And so that's required at the time of discharge. Remember, hospice election is day 0. So no later than 5 days after that hospice election. So we'd have days 0 to 5 for the admission, day 6 through 15 for the HUV1, day 16 to 30 for the HUV2. So those are your timelines as far as when you get that data collected. So this is where we're going to start talking about the SFV. So we have new quality measures related to that symptom follow-up visit. The first one is timely reassessment of pain impact. And that measure captures the percent of hospice patient assessments that have a pain reassessment within 2 days after pain impact was initially assessed as moderate or severe. And then we have timely reassessment of non-pain symptom impact measure, captures the percentage of assessments that have a symptom reassessment within 2 days after non-pain symptom impact was initially assessed as moderate or severe. So regardless of whether it's pain or non-pain, the data for these measures are collected by the hospice clinicians. Symptom impact assessments are administered at fixed time points during the hospice election, at admission, and the 2 hope update visits. So those are the assessments, admission and the 2 HUVs, where if you have assessed that this pain or non-pain symptom is impacting your patient at the moderate or severe level, then you have triggered a symptom follow-up visit. So when the patient's pain or non-pain symptom impact is assessed as moderate or severe, a hope SFV is expected within 2 calendar days as a follow-up for that pain or non-pain symptom impact rated as moderate or severe. The measurement time window begins at the date of the symptom impact screening. So on that J2050B, it asks for a date for that impact screening. And so then that symptom follow-up visit is required within the 2 days after that date. Up to 3 SFVs may be required over the course of the hospice stay, since you have 1 that may be required at admission, and then 1 at HUV1 and 1 at HUV2. That's only if the symptom impact is assessed at moderate or severe. So you may not have to do any SFVs. You may have to do 1, you may have to do 2, or it may be 3, but it's just if it's triggered. Although multiple SFVs are not required for the purpose of HQRP, it is expected that hospice staff will continue to follow with the patient. And we're going to give you some examples of that. So, the patient has symptoms rated at moderate or severe as far as the impact. You make the symptom follow-up visit. You implement, something new. You've done your symptom follow-up visit for the purposes of the quality program, the quality reporting program. And as a nurse, I want to go back again or check out the patient again to see if that works so that I can implement something else if the pain is not relieved, for example. So the data sources, what Medicare is using for this quality measure is they're looking at the records for each patient. They'll look at the admission record and they look at the HUV record. If there are HUV records, they'll identify the symptom impact assessment date where available, and they'll select assessments to be included in the hospice process measure sample if the patient assessments have a discharge record with a target date within the reporting period. All eligible assessments for a patient are included, and a patient can have multiple assessments included in the sample. So they'll select each admission record and HUV record associated with each patient assessment for the measure sample, and apply the measure specifications to the selected admission and HUV records.
And it's a 2-year reporting period for this measure.
2 years. Okay, so notice the blue, timely reassessment of pain impact, the red, calculation timely reassessment of non-pain symptom impact. So you're looking at how they're going to calculate the denominator and how they're going to calculate the numerator. So the denominator is a total number of HOPE admissions or HUV assessments where pain impact was assessed as moderate or severe. And you see on the other one, any non-pain symptom was assessed as moderate or severe. So that's your denominator. Then they take those patients and they remove in the denominator anyone who was discharged from hospice for any reason before the SFV could be completed. So in other words, they're saying, you said this patient had a symptom that was moderate or severe impact, so we're going to count it in the denominator. Then they're going to say, oh, wait, you couldn't do the SFV because the patient or caregiver declined the in-person visit, the patient was unavailable in the emergency department at the hospital or expired, so they died before you could do the symptom follow-up visit, and attempts to contact the patient caregiver unsuccessful. So you answer that question in J2052C, the reason why the SFV is not completed. And if those are true, then they're going to remove them from the denominator. Then the numerator is a number of HOPE admission or HUV assessments for which a symptom impact reassessment date was within 2 days of the initial triggering assessment date. So in other words, you assess them as moderate to severe impact of these symptoms, and you followed up and did a symptom follow-up visit within 2 days, then that's your numerator. That's your numerator for expressing this as a proportion. So they divide the numerator by the denominator, and then they multiply by 100 to get the percentage. And that's what shows up on your HQRP report. Now,
And
there is
someone
a
just
reporting
asked
threshold.
what I was talking about with the 2-year reporting period. So when we have quality measures, whether it's home health or hospice, there are reporting periods that are looked at. And so these 2 new quality measures that we're talking about, they're being driven by the SFV, have an 8-quarter or 2-year reporting period. So, if they're looking at, 2023 and 2024 together, but they're not even going to be looking at those dates. But because this is in the future here, they will look at a full 2 years when they are looking at what your percentage is as an organization. So you're not being judged just on the individual level here. You're being judged at an organizational level. What percentage of the time you are successfully seeing these patients within 2 days when they have symptoms that are moderate to severe? So it's an expectation that you do this regularly, and you want that percentage to be really high. But the time frame that they're looking at is a full 2-year time period.
And they're really not counting that for that last quarter of 25. So because you're going by fiscal year, but they're not counting that last quarter because it's actually the time period
26
and 27, and then it actually goes into place for 2028 for your annual payment update, whether they're going to take that 4% away or not.
Yep.
Now, if you don't have 20 qualifying denominator cases, you will not have a report in that QRP. So hospices must have at least 20 qualifying denominator cases, which means 20 HOPE admission or HUV assessments where symptom impact was assessed as moderate or severe during the reporting period in each respective measure for scores to be publicly reported on Care Compare. If you don't meet the threshold, then those measure scores will be suppressed. So you just won't have a score. So you need 20 qualifying denominator cases for the pain impact, and then 20 for the non-pain impact. And so, for example, you could have 20 cases where pain was moderate or severe, and that would be included. But then you didn't have enough cases where it was a non-pain, and so you would have that measure suppressed, the score suppressed. You'd usually have a dash in that place where the score would
right.
be. HQRP includes data submitted by hospices through the HOPE tool, Medicare hospice claims, and that hospice CAPS survey. All Medicare certified hospice providers must comply with these reporting requirements. And as we mentioned already, non-compliance with reporting requirements. So that means you have to submit your HOPE into iKeys. If you don't meet that 90% threshold, they will reduce your annual payment update by 4 percentage points for the corresponding fiscal year. And the first fiscal year this actually happens is 28. So I kind of misspoke because your fiscal year 26 starts October. So we have 26, 27, and then 28 is your fiscal year. And that's when the APU 4 percentage points goes in effect if you haven't been compliant. The HQRP is currently a pay-for reporting program, meaning that the act of submitting and acceptance of the required HOPE data determines compliance with HQRP requirements. Timely submission of HOPE data is a factor in determining a hospice's compliance with the HQRP requirements and the annual payment update determinations, and to be compliant for the fiscal year 2028. So that's October 1st, where October 1st, 2027 is where fiscal year 2028 starts. And all subsequent reporting years, providers must submit at least 90% per the 30-day submission deadline specified in Chapter 3. So you have 30 days to submit those HOPE assessments after you get them completed. And so that's what they're going to look at is Did you submit in time? So section J is what we're talking about today, and there's a lot of questions in section J. So we have these items in section J of the HOPE. If you haven't looked at the HOPE, it's very interesting. A lot of things are very similar to the HIS, but then there are lots of things that are different. So death is imminent, the pain screening, pain active problem, comprehensive pain assessment, the J915 neuropathic pain is new. Then we have screening of shortness of breath, treatment of shortness of breath, and then symptom impact screening. So intent and rationale intended to document the physical symptoms and the impact of pain and non-pain symptoms for hospice patients. So we're incorporating the information from the interview with the patient, family, caregiver, as well as our clinical assessment and judgment. Pain and non-pain symptoms such as shortness of breath, and we'll have the item there so you can see all the non-pain symptoms that that they're looking at are prevalent and undertreated for many populations of seriously ill patients, including those nearing the end of life. Patient family caregivers rate pain management as a high priority when living with serious and life-limiting illness. So screening for pain and non-pain symptoms will assist the hospice team with care planning, and is essential for effective symptom management and treatment. And effective treatment may include pharmacologic and non-pharmacologic interventions and will vary based on the patient and family caregiver preferences. So as hospice providers, you know all this, but this is really why they chose these particular items for these particular quality reporting measures. So here's J2050. Symptom impact screening. So no, it's kind of like a gateway here. Was the symptom impact screening completed? No or yes. Of course, no. You're going to skip to M1190 skin conditions. Yes, you keep on going. So date of symptom impact screening, like what day is it today that we're doing this screening? So symptoms may impact a patient in multiple ways. For example, sleep, concentration, day-to-day activities. So the next one is 2051. Symptom impact. So notice the time frame past 2 days. So I have determined that this patient has some symptoms that are impacting their everyday activities. So notice it says symptoms may impact multiple patient activities, including, but not limited to, sleep, concentration, day-to-day activities, or ability to interact with others. And so you're looking at all the symptoms, you're talking to the patient, you're talking to the caregiver, there may be facility staff that you're talking to if they're inpatient, and you're determining what impact these symptoms have on the patient. So we're not talking about how bad the symptoms are or how bad the pain is. We're looking at what the symptom impact on the patient is. So again, activities, sleep, concentration, day-to-day activities, just examples that you're looking at. So if you look at this key here, 0, not at all. Remember that the symptom, they may have the symptom, they do have the symptom, but it does not affect the patient, or maybe the symptom's well controlled with current treatment, like they have pain, but their pain is very well controlled. So that would be a 0, as opposed to a 9. 9 is not applicable. They don't have that symptom. So make sure that you understand the difference between a 0 and a 9. A 0, they have the symptom, but it's really not bothering them. Okay. A 9 is they don't have the symptom. Then we have 1 slight, and then 2 moderate, 3 severe. And the moderate and severe are what we're really concerned with here. So we're going to enter the code depending on these symptoms. And I said, pain and shortness of breath were mentioned specifically earlier, but included in the list, anxiety, nausea, vomiting, diarrhea, constipation, agitation. So assess the patient for the impact of symptoms, not whether they have, you have to know whether they have the symptom first, but you're not looking at the severity of the shortness of breath or the severity of the pain. You're looking at the impact of that symptom on the patient. So that's very important. And that's, words specifically from CMS. This is not an assessment of severity, intensity, frequency, or other characteristics of the symptoms listed, but the impact these symptoms have on the patient. And for admission and at HUVs, this is an overall rating of how the patient is affected by their symptoms over the past 2 days. Based on that interview, observation, your clinical assessment, your judgment, what is the impact of each symptom on the patient, and enter that code.
I know we get a lot of questions about how do you determine that impact, and it really is clinical judgment. So we don't have a tool. There's no key. It's really interviewing the patient, interviewing the caregiver, having a conversation. It's not a checkbox. I mean, it is a checkbox in there, but it's not like, oh, they told me this, so I have to answer this. There's no thing that's going to tell you that. Yeah, no algorithm. It's really like you asking the patient, well, how much do you think that pain is interfering with your sleep? Is it, less than half the time, more than half the time? You're going to have to figure out how to determine what that scoring is based on your clinical judgment. But you have to ask the right questions to get the right information to determine that. And that's an important part of doing an assessment, regarding any type of symptom or anything, is asking the patient the right questions to get to the information that you need, which is going to impact how you are doing your care planning. So if you don't ask the right questions, you don't get that information, you can't fix it for them either. And that's what we're there to do, is to help resolve some of these symptoms.
Yeah, and Candace made a comment, it could be challenging when nonverbal, cognitively impaired patients and family are not able to answer either. So it is, again, clinical assessment, what you can find out from the record, and just using your judgment.
Yep.
If that patient is nonverbal, but they're rolling back and forth in the bed and sweating
Mhm.
and eyes are dilated or whatever, you can probably say that the pain is impacting them. And so, is it
Mhm.
slight? Probably not slight. Maybe you just make a judgment that it's moderate, but then you
Mhm.
need to do something about it. So that's where I think if my pain is well controlled, then my nurse doesn't need to do actually anything about it other than to make sure I still
Mhm.
take my pain medication. So that's a zero or a slight. But if my pain medication is not working and I'm avoiding people like this person in the picture here, and I'm not
Mhm.
eating and I'm not resting, then yes, it is impacting. That pain is impacting my life, my activities, and so I need to do something about it. So I don't think this is actually new to us in hospice. We know when our patient
Mhm.
is having problems, and we know that's our job to follow up with it. It's just that now we have a specific set of items that we need to complete when this happens. So here's an example. So during admission assessment, the patient reports that in the last 2 days, their pain is severely interfering with their sleep at night. And now during the day, patient also reports shortness of breath only when going up the stairs 1 to 2 times a day. And shortness of breath only has a slight impact on their abilities. And patient denies any other symptoms. So we did a 3 for severe for pain, a 1 on slight for shortness of breath, and they didn't have any of the other symptoms. So we scored those a 9. So the next question is a symptom follow-up visit required? So if the HOPE admission or the HUV has at least one response to J50, 2051 symptom impact scored as moderate or severe, then a symptom follow-up visit is required within 2 calendar days. If they have no responses to J2051 scored as moderate or severe, then the SFV is not required. So remember, it's an in-person visit expected when any pain or non-pain symptom impact is rated as moderate or severe when completing the admission or the HUV.
And now we got a poll.
Yes, so I'm going to bring up a poll for everybody. We'll take a quick pause in the session here so you can let us know before we dive into the details of SFV. Let us know how you're feeling. We've got a poll here asking you how ready are you feeling for the symptom follow-up visit or SFV. I'm going to read through these options and then the responses or the percentages. This is anonymous, so I'll go through the percentages for anybody watching the recording. But your options are: I'm ready, we can start doing SFVs tomorrow, or I'm confident that I'll be ready by October 1st, or I need a lot more time to prep before October, or what is an SFV? And I don't see any responses on that last one, which is good. At
Yeah.
least we're mostly in those first 3 categories. Okay, a couple more seconds here to get a few more people a chance to respond. All right, I'm going to end it here and then share the results. Those should pop up on your screen. I'm going to read through the percentages. Again, this is anonymous, just for anybody on the recording. So this is a poll of the whole group. How are we all feeling in terms of getting ready for the SFV? 6% said, I'm ready. We can start doing SFVs tomorrow. 76% said, I'm confident I'll be ready by October 1st. And 18% said, I need a lot more time to prep. So we got an interesting distribution there. Hopefully by October 1st, we will all be in that A category. All right. Back to you, Lisa and Michelle.
There is a question of Section J completely new. It's not completely new, but the death is imminent is a new question. That neuropathic pain question I mentioned is new. And then all these J20 symptom follow-up visits and impact and all these 4 visits, 4 items we're talking about today are new. So some of them are new and some of them have been there for a while in the HIS. So next, let's go to the symptom follow-up visit. Go ahead, Michelle.
All right. So we've got symptom follow-up visit and SFV symptom impact. So this is 2 actual HOPE items, right? We've got J2052 is symptom follow-up visit and J2053, the symptom follow-up visit symptom impact. So tongue twister. So SFV SFV assessment findings will be reported in these 2 HOPE items, the J2052 and J2053, on the original HOPE assessment where the symptoms were identified for submission to CMS. So this is not a separate instrument, right? So we've got our admission and our HUV1 or HUV2, our discharge. SFV is not its own instrument. It's part of the admission. It's part of the HUV. We know this is very confusing and you're probably going, how is this even going to work? And it's going to be a little bit different in different EMRs. It's a lot of places are still working out what that's going to look like. It does require a separate visit. Remember, visit and instrument are not the same thing. So a lot of organizations are going to have a separate visit because there needs to be a time in and a time out, right? And it doesn't have to be done by the same person. It can be done by an LPN. It can be done by a different RN. It has to be done in those 2 days, and it can be done by a different person. So, they're going to be documenting their time in, their time out, and whatever else they're doing at that visit. They're not going there just to fill out 2 questions, right? They're going there to do an assessment of the patient and take care of the patient needs. There will be notes. There will be all kinds of things. It's a visit. And then that information either needs to be put into the admission or HUV, or it might go from that documentation automatically over to that. That is going to look different in every EMR. So I cannot answer what that looks like in any EMR for you.
No.
If you have questions about that, you contact your vendor. But it is a
We
separate visit.
We do have a couple of questions. And so I'm just going to give you an example right now because we have other examples. But I went out there and did the Hope update visit today.
Mhm.
And I determined that the pain is impacting that patient in a moderate, severe way. Somebody has to go out there within 2 days. It could be later today because it can't be part of the same visit, but it could be later today. But we have to make another visit within 2 days. That could be me. It could be Michelle, or it could be an LPN. Okay. So it does not have to be the same person.
Yeah. And we know that this is crazy sounding and confusing.
Yes. And no, the LVN, LPN cannot do the HUV. They cannot do the admission, but they can do the symptom follow-up visit. And this was specifically requested by hospice industry because they said, we don't have the RN staff to be able to do these extra visits. So they said, sure, we'll make it not a reassessment, but a symptom follow-up visit, and we'll allow LVNs and LPNs to do it.
Yep. So symptom follow-up visit, it's a separate visit, not instrument. Okay. So that's what I want you to remember in your head. This is a separate visit, but it's not a separate instrument. It's not its own instrument. Has to be in person. It has to be within 2 calendar days or later on that same day, like Lisa said, as a follow-up if they have pain or non-pain symptom impact that is rated as moderate or severe. So it's the symptom impact, not the symptom. So you might have really bad pain, right? And they might be fine. I mean, people walk around with chronic pain all the time, right? That they might rate it as an 8, but they look comfortable. They're not, rolling around in the bed. They're not hollering. It's not affecting their sleep. It's not affecting their mobility. And so they may not have a bad impact from that. So it's not about the symptom. It's about the impact of the symptom. So it's a separate visit, but not a separate instrument. You can have up to 3 SFVs during a stay because what is triggering those to occur is an admission or an HUV visit, either HUV1 or HUV2, because part of those instruments is looking at symptoms and looking at the impact of symptoms. And if you identify it during one of those, that they have moderate to severe impact, that is the trigger that says that you have to go back and do an SFV. Now, 3 is the most you can get because that's all you have is admission, HUV1, HUV2, as far as meeting that documentation requirements. So remember that HOPE is a data collection tool. It is used to drive quality measures. It's used just to collect all this data for lots of different reasons. It's not the only thing you do. It is part of your comprehensive assessment. It's not the only thing you do. So even though you might only do 3 SFVs or you might do 0 SFVs, even though you're only going to have 3, it doesn't mean that if the patient's symptoms continue to interfere, that you don't continue to do things and continue to make more visits. It just isn't going to be in this instrument. So we have to kind of separate our assessment and instrument, like what is part of the instrument, what is part of the data collection, and what is our actual assessment, what does our actual visit contain, because they're not all the same thing. So HOPE is a data collection tool, and this is a data collection tool requirement that's being used for the quality reporting program. All right. And we mentioned that can be completed by RN or an LPN.
Yeah. So the HUV itself has to be completed by an RN. But if there's a symptom follow-up visit required, that could be an LPN or LVN.
Yep. And then the SFV data elements are included within the admission and the HUV data sets and are submitted as part of that record submission for both of those time points. So there was a question here to CMS. It seems like the SFV is an additional time point, and they said no. The SFV is considered a follow-up to the admission and HUV time points only if a symptom is noted as moderate or severe. Any SFV data would be submitted along with those time points if applicable, because those data collection items are buried in the admission and the HUV. So SFV requires another visit, but it is documented as part of the admission or HUV as applicable. No separate instrument. So J2052, symptom follow-up visit. This is included in the admission, HUV1, HUV2. So this is what it looks like. And it tells us right here, an in-person SFV should occur within 2 calendar days as a follow-up for any moderate or severe pain or non-pain symptoms identified during the symptom impact assessment at admission or HUV visits. So when we're looking at this, it's saying, was an in-person SFV completed? Our choices, we can put no, or we can put yes. If we put no, we're going to skip down to J2052C, the reason why. If we put yes, then we have to put the date that it was done. And so that date that it's done, that's part of that QRP program is, was this within 2 calendar days of when you did that admission or HUV? So this is how they're tracking it based on the date that you put in here. So it better be right. Don't just wing it. Don't just make it up.
So it's going from that question in the HUV and in admission, because you have to put the date of your symptom impact visit. So your admission may take longer than one visit. So that visit is where they're counting the 2 days from.
And then we have reason SFV is not completed. So we can choose from 1, patient and or caregiver declined at an in-person visit. So they declined an in-person visit because this has to be an in-person visit, not a phone visit. 2, the patient is unavailable. For example, they're in the ER, the hospital, they travel outside of the service area, or they expired. Or 3, attempts to contact the patient and or caregiver were unsuccessful. Now, remember when Lisa was going over the calculations and the exclusions, if you're answering 1, 2, or 3, because it wasn't done, they're going to be excluded. So it's really trying to capture other reasons you might not have done it, not these reasons 1, 2, and 3. So if they expired before you could do that SFV visit, if they declined to let you in person during that time frame, or you couldn't get a hold of them during that time frame, those are going to be exclusions for this. So kind of interesting. So make sure that you're accurate in the date and that you're accurate in the reason why it was not done. All right. As we mentioned, this can be completed by RN or LPN. We're completing it only if J2051 symptom impact is marked as moderate or severe at the admission or at the HUV. It has to be in person. It has to be within 2 calendar days, and it cannot be conducted during the same visit. It can be on the same day as your initial assessment, but it can't be during the same visit. So we talked about this already. When to answer no or yes, it's really, did you do it or did you not do it? And if you didn't do it, why didn't you do it? If you did do it, what day did you do it on? And if you did do it, talked about those. If you did do the SFV, then you're going to have to basically look at that symptom impact again and give it a rating. We talked about these exclusions here already. So incomplete or missed SFVs, if not excluded, will be included in the calculation of that quality measure. So like I said, if we're saying we didn't do it because of response 1, they declined an in-person visit. Response 2, they were unavailable. Maybe they expired. Maybe they're in the ER. Or response 3, we were unable to contact them. If you mark one of those, they'll be excluded. But if you just didn't go because of scheduling issues or whatever, it's going to count against you.
Michelle, a different Michelle had a good comment. I don't understand why you can't complete SFV if they're in the ED or hospital. You can. You can go to that facility and do the SFV as long as the facility allows you to do so. But if they're in the hospital, under hospice, certainly you can go to the hospital and do the visit, and that's to your benefit to do that. Of course, it's to the patient's benefit as well, because if you've made that symptom follow-up visit within the 2 days, you're getting credit on your QRP. So you can either use it as an excuse to not do it, or you can go ahead and do it and get the credit. So I would say if you can go and do the symptom follow-up visit, then that's best.
And then we've got J2053, the SFV symptom impact. So it's similar to our other symptom impacts, but this question is only showing up. It's only going to be populating for you to fill out after you say, yes, I did an SFV. And now here's what I found at the SFV. I looked at those symptoms again and determined what the impact of those symptoms were. Were they interfering with sleep or concentration or day-to-day activities, their ability to interact with others? Those are just examples. So what was it interfering with? Any of these symptoms, and how severe was it? Not at all, slight, moderate, severe, not applicable. And we do have to have a response in each of these items. So there's no blanks. You can put 9 if it doesn't apply. And even if you continue to have moderate to severe symptoms here during the SFV, that is not a trigger for another SFV. Now, you still are going to want to follow up with the patient and continue to assess these things and give them the care that they need, but you don't need another data collection tool. This is not a trigger. This you had to do because of a trigger at the admission or the HUV, but you don't just go SFV, 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 SFV. It's only part of that admission or HUV. All right. So this J2053, it's part of that follow-up of symptoms that we're doing if prompted, if they had moderate to severe symptoms at the admission or at the HUV, RN or LPN. Each symptom listed has to have a code in there. So you're going to put 9 if it's not applying. And it's based off a patient caregiver interview, observation, clinical judgment. You got to ask the right questions to get the right answers. All right. So here we have an example. During the admission visit, J2051, pain and nausea are both marked as severe. Interventions are implemented and the nurse returns the next day to complete an SFV. During the SFV, the impact of the nausea had improved to mild and pain is down to moderate. Is another SFV required? And so, no, you don't have to do another SFV. So if there is evidence of ongoing moderate or severe symptoms during an SFV, you don't need another SFV for QRP purposes, for data collection purposes, but you want to provide good care to your patient and continue to work on that symptom management, because that ultimately is why we're there. We're not just there to do data collection, we're there to take care of patients. And here we've got another example. During admission, the RN assesses J2051 pain impact as severe, returns in 2 days for an SFV. The HUV1 is done on day 11, and there's no further symptoms. HUV2 is done on day 24, and J2051 reveals pain that's severely impacting sleep, and that triggers another SFV visit. The RN returns on day 25 to complete the SFV, and the RN visits on day 26 to assess the pain. The patient expires on day 27. Which time points are required to submit? Now, this one's really tricky. So if you don't have memorized the rules about the HUVs, this one would be tricky. So we know, we did the admission, we did the SFV, we did the HUV1, we did the HUV2, we did the SFV, but we really have to think about the HUV time points here. So given the length of stay for this patient, the HOPE admission and the HUV1 are required to be completed and submitted. They have to be. But a symptom follow-up visit is required when we have moderate or severe symptoms are found during an admission or an HUV. The submission of the HUV2 that we did here on day 24 is optional because the patient died before day 30. So you only have to complete the HUV2 if they've gotten to day 30. You can do it in that 16 to 30 day window, but it doesn't have to be submitted. But you did something good here, right? You did an SFV in the time frame that is required. So you went within that 2 day window and did that SFV. That's a good thing. That's going to help your QRP. So it's helping for that quality measure. So you would want to submit that, in order to get credit for that quality measure. We don't want to exclude anything if we don't need to. If you're doing the right things, you don't want to exclude these things, or you want to have them continue to be included. So you would want to submit it in that case. And here we've got an example. Patient complains of constipation causing a significant amount of distress at HUV1. The RN implements the standard protocol. The LVN visits the next day to give an enema with limited results and finds the patient with a significant amount of METS pain impacting his day-to-day activities to a moderate degree. The constipation still impacts the patient to a moderate degree. The RN is visiting tomorrow. How many SFVs need to be completed? Although multiple SFVs are not required for the purpose of HQRP, it is expected that the hospice staff will continue to follow up with the patient based on their clinical and symptom management needs. So as we've mentioned, the admission and the HUV, that's where we get the triggers to do the SFV. So it's never going to be admission, SFV, SFV, SFV. That doesn't happen because it's part of the admission or part of the HUV, but you still follow up with your patient and give them the care that they need.
So in this case, you had an HUV1, you had a symptom follow-up visit, and you're done with the HOPE, at least. You're expected to take care of the patient, but you're done with the HOPE assessment.
Mm-hmm. And here we've got another example for you guys where we've got the answers kind of all filled in here. And so, the PDF of these is going to be helpful for you remembering how to do these things and use it, for example, for your staff and things like that. So during an admission on 10/20, the patient reported pain severely interfering with sleep at night and nap during the day. The patient also reported shortness of breath only when going upstairs 1 to 2 times a day. Shortness of breath only has a slight impact on their abilities. Orders are received at admission to begin morphine around the clock. The SFV performed on 10/22, and the patient says the pain is much better and they have been able to sleep through the night. The pain is no longer affecting the activity. The effect of the shortness of breath remains slight. The patient is now experiencing some nausea that is affecting their ability to eat a little more than half the day. No other symptoms are identified. So was an SFV completed in person? Yes, we did. What day did we do it? So that's the day the SFV was performed, not the day the admission was performed. And then we're going to go through each of these. Pain, there was no more impact when they did the SFV. The shortness of breath was slight. The anxiety was not applicable. The nausea was moderate. And then the vomiting, diarrhea, constipation, agitation, those were all not applicable. So we have to have a response in each of those items. And then this is just a little cheat sheet for you guys looking at the different time points. Notice SFV is not a time point here, right? The assessment time frame, when the record completion goal is, when the record submission goal is. So you have to have everything submitted within 30 days. The recommended completion goals are 14 days for admission, HUV1 and HUV2, and 7 for discharge. So that's just kind of a
recommended, not a hard date.
Yeah.
You have to get completed. It is recommended. However, the submission is a deadline. There's no recommendation there. It's a deadline.
Yep. You want to go over this example? You made this one.
Oh, yeah, I made this one. So the patient has a scheduled HUV2 on day 19. Thursdays are his regular visits. The family calls on day 17. So before his HUV2 is actually on the schedule, it reports increased shortness of breath and anxiety. So the RN visits and finds the patient very agitated. He reports that he cannot relax and cannot sleep. He is suffocating. Anti-anxiety meds are started and the HUV assessment was completed. And then we have the symptom follow-up visit is made on day 19 and the patient's fine except for his usual shortness of breath. So what we have on the HUV as far as symptom impact is that we have the pain is a 9, shortness of breath is a 3, anxiety is a 3, and then we have a 3 on agitation with the rest of the symptoms 9s. Our symptom follow-up visit within 2 days. We have the 9 on the pain, 1 on the shortness of breath. His anxiety is well controlled, so it's a 0. And so is his agitation, so that's a 0. And then everything else is 9.
And then this is just a reminder of the QRP cycle. So QRP activities operate on a cycle of data collection and submission, compliance determination, and payment impact. This is the hospice QRP fiscal year reporting cycle. The data collected will impact hospice payments 2 years later. So this is right in the guidance manual. That's right where we got this picture from. So 2026.
That's why I got confused earlier, because it says January to December calendar year 2026.
Right.
For hope, when it actually starts in October fiscal year 2026. So
yeah.
And then your APU is in effect for fiscal year 2028, which is October 1st, 2027.
Right.
I should have waited till this slide to talk about that.
I know. We can't memorize all the things. We need the stuff to be in front of us.
This is official right here.
Yep, right from the guidance manual. All right. So what do we want to take away from this? Act now. Don't wait until October, guys. We want to make sure we're avoiding financial penalties, because non-compliance with the 90% submission threshold is going to directly impact your reimbursement. Nobody wants to get a 4% reduction in payment because they didn't get these HOPE assessments submitted timely, right? Training and process change. The HOPE assessment introduces a more comprehensive framework compared to his, and your team will need adequate time to train on the new assessment and adapt workflows to meet submission requirements. Now, we did in January do a 4-hour HOPE assessment training. We have another one coming up in June. This is a link to it. If you guys are interested, we're going through the entire HOPE assessment piece by piece. We do also have a whole extended HOPE training in the Post-Acute Academy as well. So if you need it for lots of staff, we have corporate pricing on that. We're glad to talk to you about that. Vendor selection takes time, so we want to make sure you're partnering with a reliable vendor. You have to have time to do research, negotiation, onboarding, training. These are some big changes. Starting early ensures that you're operationally ready for October 1st for getting those things submitted to IKEYS appropriately. And compliance impacts quality reporting. That's kind of the point we've been trying to make with this. That is the reason that these items are in there, is for the quality reporting program. HOPE submissions will influence public-facing quality metrics. Non-compliance or inaccuracies could harm your agency's reputation and marketability. And I think Sam's going to put a poll up here in a minute, but we just wanted to let you know we are meeting with people. If you are looking for education services for all your staff, we have corporate pricing on it. Post-Acute Academy is our one-stop shop. It's video-based learning with quizzes. It's self-paced. We have the entire HOPE assessment broken into different sections in there. We have all kinds of other hospice courses related to, star ratings, long length of stay, you name it. We've got it in there. Plan of care, case management, all these different things. Somebody said, "I love Post-Acute Academy." Thank you. We hope you love it. We love making the material. So, and that is our passion, is education. McBee also offers coding and HOPE review services. So, we do coding for home health as well, and OASIS review, but we also do coding for hospice, and we are building out what our HOPE review is going to look like right now. So that the HOPE part is something that will come in the future, but if you need help with hospice coding now, we can definitely do that as well. And I will say,
It will not be any different for timing if we are following the requirements currently for comp visits correct. Seems the biggest change will be for patients who require SF visits. So the HFVs, days 6 through 15, and then 16 to 30. So whatever that
is different than what you're doing with his. They're different, and they are data collection time points.
If the clinician documents that the symptom is controlled or relieved during the visit, will the SFV be required? No, if you are saying that pain exists, but it's a 0 because it's well controlled right now, the patient doesn't feel like it's a big thing, then you're counting that as a 0. You only have to do the symptom follow-up visit if you're saying that it's moderate or severe. So the SFV will not be required in that situation. Winter weather is not specifically excluded. So if there's winter weather and you can't get there to do the SFV, that's not excluded. That would be a 9, and only the 1, 2, and 3 are excluded. Let's see. Jamie, I'm not sure for the reporting 2026, 2027, if you just refer to that slide that was just maybe 3 slides back, that is for the first reporting period and when the impact will be on your annual performance update. And so it's a 2-year collection period, and I don't know whether it's going to roll over or I think probably a rollover. So 27, 28 would be for 29, but I don't know. I don't.
They haven't broken it all out.
Yeah, I haven't seen where Medicare has provided any additional information on that.
They said it will be coming soon in the upcoming town halls and ODFs, which they canceled the February one. So,
and again, we have a QRP manual that is still draft, and a HOPE manual that is final, but they say they're still going to make changes to it. So we just have to kind of wait. With the SFV, the 2 days is within 2 days. So we don't really worry about day 0 there. So if I had a visit on the 17th where I had symptom that was impacted moderately or severe, I need to visit that patient by the 19th because it's that day or within 2 days after.
Danielle has a great question here.
Okay.
Yet documentation must support the selection of the checkbox. Any guidance on how we should support this clinical documentation? great point. Don't just check the checkbox. You should explain it. When I said you got to ask the right questions, right, to get to the answer. If I ask my patient questions and they tell me, oh, you know what, my stomach really hurts me when I go up the stairs, when I'm getting on and off the toilet, when I'm getting in and out of the tub, I want to put that in my narrative. How do I judge whether something's better or not if I'm not quantifying it with that discussion in my narrative? And you want to make sure that all of your documentation is supporting why you're there, supporting what you're doing for that patient, how you are addressing those symptoms. But you have to be doing a good assessment. And you have to be documenting it first and foremost. It's not just the checkboxes are part of the data collection. Your assessment, those are just in your assessment. They're part of your assessment, but it's not your entire assessment.
A scenario where there would be a symptom impact screening would not be done. Now you do the symptom impact screening, and it's part of the HOPE assessment. It's whether you do the next visit that is, whether you have screened them as having the symptom that is moderately severe impacting them, then you have to do the SFV. But the screening itself should be done regardless. Yeah, symptom screening not done. I'm not sure, Michelle. I will have to look that up. If you'll email me, I will look that up for you.
I think a lot of these we did answer in the thing as well.
Yeah, I'm just kind of.
There's many questions, guys.
Yeah.
And I know you guys can't all see each other's questions either. It doesn't show you all of them.
Rivka had a good question. Severity of the symptom versus impact, very nuanced. And if you read some of the guidance is pretty clear on this in the HOPE manual. But when CMS gives us an example, sometimes they mess it up too. So it's like not clear whether they're talking about the impact of the symptom or the symptom itself based on how it's worded. So they it's not real clear in the examples, but it is clear in the guidance itself. Can you clarify which disciplines can do the symptom follow-up visit and the HUV? The admission, the HUVs, the discharge, RN. The SFV can be the RN or it can be the LVN/LPN. There was something about, follow-up, the LVN doing the follow-up to the RN's visit. Remember, there's a Z400. I was thinking maybe we should have put the Z400 in this presentation. But Z400 is where everyone who contributed to the HOPE items signs their name and puts which item they contributed to.
Yes.
So if I'm the LVN that did the symptom follow-up visit, then I would sign my name and say, I did 2053. So that is what they're expecting, that there would be the signature of the person who completed that. Like an admin person can do some of the admin items. And so they would put their name there that they completed those items, like the Medicare number and all those kinds of things. So Z400, take a look at that one.
Yeah, that's a very good point. I know that is making a lot of people nervous, but
yes, it is.
Everybody that works on the HOPE assessment is going to it's going to be in the system who did what part. So if they did part of Section A, they're going to put they did part of Section A. If they did part of Section J, they're going to put specifically what part of Section J they did. But that is going to look different depending on what EMR you are using. So if you have questions, reach out to your vendor directly. Like we said, we're not, this is a general one, not anything EHR specific. And I know a lot of things are in the works with all the different EHRs. And I know NetSmart has some, what is it? Their group that they have.
User group.
Yeah, there's a user group. So you can find information about that. And we'll be continuing to have webinars as we hear of changes along the way. We're all watching. We're all reading the Alliance emails every day. We're on all the listservs. So as things come up, we will be putting out more webinars. And if you guys have any ideas on additional content you would like to see, put it in the chat, email us directly. We want to make sure we're putting out the content that you want to see. So if it's a hot topic and you want to know more about it, let us know. And we're glad to do it.
Daniel, I had another question about the LPN and RN, and one is doing the HUV and one is doing the SFV. And is there an expectation to keep the document open until this item is populated? Remember, the HUV is not complete until those items are complete. So that would be your completion date, is once that SFV information has been added, 2 days later.
Very good point.
As I said, completion goal, this is a suggested completion goal of like 14 days, but then the submission deadline is 30 days from completion.
All right.
Okay. All right, we'll wrap up there then. Thanks everybody for your participation, for joining us today.